Hello, EMSNation. I'm your host, Faizan Arshad, and we pick up right where we left off to bring you the highest quality pre-hospital content and lectures coming from the CCTMC conference, and that is the Critical Care and Transport Medicine Conference, which is put on by the Air Medical Physicians Association every March. And on the line, I have Dr. Chris Fulagart, the president of AMPA. Welcome to the show, Chris.
Thank you very much. I'm very happy to be here, and it sounds like we have some exciting talks lined up over the next few weeks.
The feedback has been so positive for all the CCTMT lectures and contents that we've been posting on the EMSNation podcast, and the people are asking for more. And I feel obligated to oblige them. I'm not sure I'm apologetic for that, Chris. How do you feel?
I completely agree 100%. And this is very exciting, and I'm glad to be doing this with you.
So today is episode number 30, taking a timeout before initiating RSI improves patient safety as well as first attempt success. And giving this incredible talk, we have Kevin Colopy.
Kevin is actually the clinical education coordinator for AirLink, VitaLink Critical Care Transport. He has extensive experience and is actually up to be the next president of the Paramedic Association. I think you guys are going to enjoy this one. It's an extremely important topic. We really want to get this right on the first time, and taking a time out has actually been shown to improve safety in this important procedure that we do.
I think this is such an important topic, and Kevin does a great job not only mixing his own services data with, papers on a national level and scope that really help bring this idea to light. And I think are also encapsulation of the term RSI, typically known as rapid sequence intubation, is evolving. And Dr. Rich Levitan describes it as an RSI being a resuscitation sequenced intubation. So that includes resuscitating your patient beforehand, getting your appropriate safety checks in, using a timeout to make sure everyone on the team is on board, as well as employing a checklist. It is certainly going to be an exciting episode. Stand by for this one from Kevin Colopy.
Get started. My name is Kevin Colopy. I'm the clinical educator for Airway and Critical Care Transport. About 4 hours east of here in Wilmington, North Carolina. It's that little finger that sticks off on North Carolina if you're ever looking at it on the map. And I also happen to be the vice president of the International Association of Flight Critical Care Paramedics, and I'm very happy to be back here today. This year, I was here at CCTMC last year for a couple of talks, and apparently I did okay enough to be invited back for what I really think is a really cool program that we've developed at Airlink and VitaLink with our RSI timeout. It's worked very well for us, and I hope you guys can take a couple pieces away from it and find that it might work well for you too. Being a paramedic, I have absolutely no disclosure because no one in the industry wants to spend any time endorsing a paramedic. If anyone is in the industry, by all means, I am open for sale. But I do have no financial interest to disclose. I absolutely love this study that was put out a couple of years ago. It's in a fairly small journal, Pre-Hospital Emergency Care. Unless you're really active in pre-hospital care, most people don't see this journal, but it's one of my favorite quarterly journals to receive. And in 2010, they did a study that said, what does it take for a new paramedic to have any chance of being good at pre-hospital intubation? And arbitrarily in our industry, we've identified this being good as 90% first attempt success. And what they figured out is if you don't have 25 successful intubations on either high-fidelity simulators or actual patients, in your initial training, you will not be a good intubator. For those paramedics in the room, please raise your hands if you got 25 intubations in your initial training. That's usually about the response I get, like 3 people. I got 8. I was really lucky. I had the most in my entire program, and I had 8 live intubations. And when I went to paramedic school, we didn't have high-fidelity simulators. So it really begs the question, what are we doing to prepare our staff in critical care transport? So a couple things I want to talk about in the next 25 minutes. What are our national standards and benchmarks that we've set up and put in place? Talk a little bit about the joint commission policy on checklists for high-risk procedures, and really where I saw this is when I started going to the OR and seeing them take a timeout before every high-risk surgery, which in today's world is every surgery. Talk about the value of a peer-to-peer confirmation of readiness prior to beginning the intubation process, and then talk about how it's been successful for us. So, there are some predictors that are out there that say, hey, you're really likely to be very successful at intubating patients outside of the hospital. And when they looked at this study and they looked at just over 700 intubations, what they found is you are most likely to be successful if your patient has no blood pressure and has a DCS of 3. Pressure's off at that point in time. What they found is when your blood pressure became higher or when it was critically low, you were less successful in first attempt success. Kind of intuitive. Our stress goes up a little. We become a little more anxious with it. And the more abnormal your end-tidal CO2 was immediately afterwards, the more likely it was you were going to be unsuccessful in overall success. And in this particular study, their paramedics had a 61% first attempt success and an overall 81% success rate. It is important to note that this was from 2006, it was a little bit older, and while they didn't specify it, most likely most of the paramedics in this study did not have RSI available to them, but it does show some of the problems that exist to us. This is a really interesting study that came out just a couple of years ago, and one of the names of the authors will have to be speaking a little bit later in the conference, and I strongly encourage you to see this through Dr. Disney's presentation, but what he looked at with his colleagues was, does your position matter? Does it make a difference if you intubate them on the floor or intubate them in the ideal position on a bed, above chest height? Put a pillow underneath the patient's head and get them in that ideal position. They found absolutely it makes a difference in your first attempt success, whether you are laying completely on the ground in a low position, which they were trying to imitate seated in the back of the manual for the patient on the stretcher, or bringing them all the way up to chest height. And they found you were most successful if you took the patient on the stretcher and raised that stretcher up to chest height. And when you read it, you're going, well, duh, why don't we ever practice this? Every intubation we practice in school is on the floor or in some weird position. And it's pretty well reflected in our data when we go back and look at it, and we find that fewer than 10% of our patients that we intubate, we put in that ideal position, even though we know it's going to set us up the most for success. Why? We're probably in a little bit of a rush when we go and manage these patients outside of the hospital. This was a little bit tough to read, but this is one of the first studies that looked at, does it make a difference if you introduce a checklist in emergency care? This was in the emergency department on getting ready for intubation. And when they put a checklist in the emergency department, they found emergency medicine physicians and the residents were more likely to RSI than they were just simply do a crash intubation or drug-facilitated intubation. And what it really makes you think is it took a second to make sure they were ready. Instead of rushing, I have to manage this airway, they had to go for a checklist and say, okay, let's take a second, make sure we have everything we need. Interestingly, this didn't really make a big difference in this particular study in overall success. But what it did make a difference in is your post-intubation care. They were better prepared and they were more likely to give the appropriate drugs after intubation as well, even though this particular one didn't show overall first attempt success. So in 2015, they did a meta-analysis of over 7 million EMS transports. They looked at every single EMS medical record, out-of-hospital medical record, and while they can't split out critical care and inter-facility transport, we are a piece of this. If you've done any sort of electronic medical record, you submit to NEMSIS, and you are included in this database. So they looked at over, like I said, 7 million records, and they were looking at our critical procedures. And they were defining critical procedures as things like cardioversion, pacing, intubation, chest decompression, aspirotomy, chest tubes, etc., etc. And they found that, on the whole, EMS providers only perform critical interventions on 2.4% of our transports. And when they slice out intubation, we do, on average, an intubation for every 0.6% of our transports. That's not a lot of intubations. It really solidifies that we aren't managing a lot of airways in out-of-hospital care. It by no means says we shouldn't do intubations. We've got things as we go further down the list, like less than 0.1% of them we cardiovert, because we pretty well argue that we need cardiovert. What it says is we have to practice these high-risk critical skills a whole lot more. We have to prove we are not performing them a lot in the field. They also did a meta-analysis the same year, and I really liked this one, and it created a little bit of Twitter buzz last night. I asked a couple people to prove it when I said this. So they did a meta-analysis. They queried all the information that was available on pre-hospital paramedic intubations and physician and emergency medicine intubations. And what they found is we're actually pretty similar. When we look at the overall odds of intubation success, ground paramedics in cardiac arrest had a 91.1 overall intubation success rate. Physicians, 91.8%. Overall, paramedics were 87.5% successful. Emergency medicine physicians were 91.8%. By no means am I ever trying to stretch here that paramedics are as good as physicians at intubating. I'm simply saying in this particular study it was similar. We had an interesting conversation over the weekend on when paramedics put on their resume they're an airway expert. And we talked about how everyone in the room said they take that resume they shred. Unless you're a CRNA or an anesthesiologist, it's very easy to argue that you're by no means an airway expert. You can be an airway passionate, I like to think I am, but we cannot pretend to be an expert to someone who's actually gone to school to train on how to manage airways. We need to sponge as much information from those people as we absolutely can, and always tell them that they know more about it than we do, and please teach me as much as possible for those patients. But we do know that first attempt success matters. In 2013, we saw that the number of attempts directly correlates to the number of complications you can expect to see in your patient. Ideally, we want first attempt success because that's the fewest complications. At 3 attempts in this study, there were 63% of the patients had complications later on. And if it took more than 3 attempts, that jumped up to over 70% of those patients predictably had complications. So by all means, does first attempt success matter? Absolutely. What we have to realize is there is no way for us to say we are always going to have first attempt success. So we have to be as prepared as possible for that second and third attempt. If you don't have a plan for your second and third attempt intubation before you start your first, you've already failed your patients. That was the whole idea behind what we ended up developing with our RSI timeout that we developed. And there we go. There we go. So where's the problem in pre-hospital intubation? Is it in our classroom training? As an educator, I would like to think not, but it probably is. Is it in our preceptorship training? Absolutely. It's in our initial program training. It's in our annual competencies. And here's why. Because every time I go to the OR, I learn something new that I need to go back and teach people. If I get back to my paramedic instructors who taught me how to intubate, they were teaching me bad habits from the start. If I look at the people that wrote the first airway lessons in the textbooks that we learned from, they were not anesthesiologists or CRNAs. So by no means do we have the best people possible writing this. So what we truly have is a systemic airway management problem that we need to look at and figure out how to improve it every step along the way. It's not saying we're bad. It's owning the opportunity for us to get better throughout our entire spectrum of training and practice in airway management. So here are my program's completely arbitrary goals for airway management. Because when we were trying to set up our goals, I went to our chief CRNA and one of our anesthesiologists and said, what's realistic? In the literature, we're supposed to be striving for we are bad providers if we can't get 90% first pass success. And in North Carolina, your intubation is defined as an attempt. Your blade goes in the mouth even if you do not put it in an ET tube. And we have to stick by the state definition. And he looked at me and he said, 90% we don't even get that here in the OR. He said, what I want is 100% airway management. I don't care how you manage it, I don't care how long. He said, I want you to be able to recognize you have a problem, stop and fix it, and then manage that airway. And then managing that airway does not mean you have to put a stupid endotracheal tube in the patient. You have better means for managing it, and you should be celebrated for that. And so we took that back and said, we never want to punish someone because they were practicing such a thing. We never want to punish someone if they looked at it, they sucked in the airway and said, this is stupid, I'll never intubate, and they put an 8-hour in and kept that patient from becoming hypoxic by sucking them all the way to the closest hospital. They should be rewarded for that, they should not be penalized for it. So what do we want right now? We want 80% first attempt success. Because you really don't know until you get in there what you're absolutely going to get. Within 3 attempts, I want 90% of the time we've successfully intubated that patient. But I also want 100% of the time the airway is done being managed within those same 3 attempts. So if someone looks twice, I don't want them to go back in and have to go fourth, fifth, sixth time. We aren't doing that patient any good. We need to be done it 3 times because at that point, we aren't doing our customers any good, and we aren't doing our patients any good to be continuing to manage. We also had to accept there is a profound difference between practice and proficiency. And we need to be demonstrating both on a regular basis. Practice means I walk in and I can intubate Fred the head. And after you've intubated Fred the head 4 times, you know you are going to intubate him with a MAC 4 blade and a 7.0 and a tracheal tube with a little bit of lubrication on the end. And there's no thinking that goes into it. Proficiency is recognizing when that skill needs to be performed on Fred the head and how to do it in that given situation in the whole context of practice. So some things to think about. We know we need 20% or 20 intubations or more to predict 90% first attempt success in pre-hospital care. We know we need to maintain competency. We know Keynes now says you need to practice every airway skill every quarter. So if you're going to put Keynes in, you better practice the Keynes every quarter. If you're going to do retrograde airways, you have to do retrograde intubation every single quarter. Whatever it is, you better be practicing all every quarter. And really touching one piece of equipment once a quarter for something so important once is not enough. You need to be practicing as much as possible. And something else you want to think about is, do we practice how we're playing? By that means we walk in and just intubate by the head as I can, and I think, well, I need to do my daily intubation. Walk up and intubate him. Or do you really spend most of your time practicing how you want to perform and making people intubate in the simulation lab in context when it's appropriate for that simulated patient that's going to be deteriorating in front of them, and not only making them pick their equipment, but making them calculate and draw up those drugs every single time. That is going to build proficiency. And as I said it before, we need to ask the question, do you routinely have a plan in place for your next attempt before your first one begins? And I will be the first one to stand up here and say, for the first 15 years of my profession, in my job, I did not. Because no one taught me how important it was to have that second and that third plan. I knew I had a tank for a backup, or surgical airway, or these other pieces, or that there were different sizes. We talked about it, but we never practiced it. So because I never practiced getting out 3 different ET tubes and 3 different blades, I never did it in the field, so I never had that backup plan. Fortunately, I never had a detrimental outcome for one of my patients. I got lucky. The truth is, I probably should have got caught with my pants down one of those times. So some things we saw in the simulation lab, we started doing simulations at our program. I routinely heard the phrase, I had suction out and ready, but the reality was it was always still in the packaging. I have capnography ready, but because it's a mannequin, no one actually bothered to set it up and put it on. They knew where it was the answer I got. My backup is ready, but when we started, our backup airway was in a different phase from our original course. Our ET tubes. We really weren't setting ourselves up for success. And we often tried the same blade twice, and while I always put a bougie out, its use was extremely low. What I found out is when we added it to our program, no one was really in service on use of the bougie or how it can be helpful, so we had to spend a lot of time practicing with it. So that brings us to the Joint Commission, and in 2015 they said you need to have for all your high-risk procedures a timeout that is performed every single time. And they said it needs to be performed as consistently as possible so that it's incorporated into a standardized protocol to truly improve patient safety. And I'm not going to read all of the words that it says here, that it spells out what the Joint Commission is actually looking for in a checklist. What they're telling you is it promotes teamwork. A checklist forces us to work together so we're all on the same page. It recognizes that the timing of how you implement a timeout checklist has to be unique to your program. So they're not going to tell you how to do it, how many questions, what they're looking for, because your procedures that you use it with are going to be unique to the institution in which you work. The scope and the depth of that timeout checklist has to be unique depending on the procedure, your programs, and your skills. But it has to be done consistently each and every time you perform it. If we aren't doing it consistently, it totally defeats the purpose of taking a 10-second, okay, time out, stop, is everyone ready, and what are we going for? So here is my timeout checklist. This is what we created at our program. it asks 11 questions, and it's a challenge and response checklist. So we're looking at it. I've got a couple of staff members here, and they're here to actually have them with them. They wear them on their badge cards. It's 1.5 inches wide by 3 inches long, and I'll email this to everyone. I've tweeted it out before. It's absolutely helpful. And what we ask is on the left-hand side is what the first person says, and on the right side is what they are looking for as a response from their partner to say, yes, we are ready to go. And we go through all 11 of these points before we start. So the first thing we ask for is suction, and it has to be turned on and in reach. That means every single time we're intubating somewhere, they actually turn on suction in the back of our customer's ambulance or inside that emergency department, and it's right next to the patient. BVM, that first intubation at my program where I currently work, the person I was flying with, who's been flying for probably about 16, 17 years, was a brilliant clinician, and I would trust him to work on anyone in my family. He and I were flying into a patient we knew was head injured, combative, and needed to be RSI, and we had 11 minutes to wait before the ambulance showed up. We had all the drugs drawn up, we had to wait, we had everything laid out. We jumped in the ambulance, we intubated, and guess what? We didn't have a... Doesn't matter that it was 1:30, 2 o'clock in the morning. The most basic piece of equipment was not out and available, and that was the DVM, because everyone else thought someone else got it. So the second thing on our list is this outlet's connected to oxygen. The nasal cannula. We perform haptic oxygenation on 100% of our intubations at our program. Whether or not it works, there's a lot of debate on it out there. It doesn't hurt. That's the bottom line. Even if it doesn't help, it's not going to hurt your patients. So, as soon as we have it available, we turn it on 8 to 12 liters per minute. Equipment. We look for both blade and a backup. So I want 2 laryngoscope blades out and available. The size they think you need, and their alternate blade that they think might be available and you might need. And also 2 ET tubes, both out, both tested, both ready. And I don't care. That means we're going to waste it because we have disposable laryngoscope blades. Hospital said we had to go to them, that's okay. It costs $6 a piece. Why we make them get it out is because now they are more inclined when they go in and they say, wow, this isn't the right one, the next one they have is already right there. It's not back in the bay. They don't have to get something out. They're set up to be promoted to say, wow, I need a different option. It's right here. I'm more likely to use it if it's out available than if it's still wrapped up inside of the bag somewhere. So we wanted to set those people up for success. Our drugs, this is not the time to go through all the drugs you might need during RSI because your pre-medication drugs are better needed before a 10-second timeout. If you have a question, you say, well, I have fentanyl here for pre-medication. I'm not going to take effect before you induce this patient. So what we're focusing here on is our induction agent and our paralytic. And this is probably one of the most helpful steps because it makes sure everyone knows which drugs are being given and the doses of them. And it's just our last opportunity to catch drug errors. Because you don't want to double your dose of ketamine if you can help it. Then we look for our alternate airway. We've really tried to abandon the phrase backup airway device. We're trying to move away from it because I want someone to be encouraged to say, this is stupid, I'm going to go rapid sequence tank. Or I need to go rapid sequence surgical airway. Or I need to do something else because it makes sense for the situation that I'm in. Or we're going to try once and then go to our next airway. We shouldn't be approaching it as, wow, you had to put in a thing, you failed to manage this airway. You couldn't intubate the patient. You managed the airway, you prevented hypoxia. I want to celebrate that. Now, if you couldn't intubate 9 patients in a row, maybe we'll talk. But you might have the worst 9 airways possible. And you aren't doing anything wrong, you just have really crappy airways. What we're finding in our program today is we end up having to manage the airways that our referring emergency medicine physicians don't want to. How can I expect it without getting the most challenging from small critical access hospitals? So then we get to our McGrath. We want our McGrath out and available, and I mandate the use of our video laryngoscope on 100% of our intubations, unless our staff can say here's why I didn't use it. And if they have a really good reason, like I opened it up and it didn't turn on, or there was so much blood in the mouth, I just wanted to go in and follow the bubbles because it made sense, and they need blood, if it got on the screen, it's probably just going to occlude it. Well, then I'm going to support you for that decision. So we just look for a reason why they did not use it. Capnography is set up and available. We obviously want waveform capnography. I don't think we need to say any more about that. And then Lowell's clear. Probably one of the best pieces, best ways to include everyone else on the scene is everyone know what their job is. And the most important job we assign is the person standing in the corner, and I walk up and I say, okay, Jim, your job Your job is to grab my left hand if their pulse ox drops below 93%. And we use 93% as our cutoff. Because we know at 93 you're very likely to hit 90, which is procedural hypoxia. And why I tell them to grab your left hand? Why? Because that's my laryngeal point. I don't want to be tapped on the shoulder. I don't want to be told, excuse me, and it's noisy, they don't really hear me. I want to hear them grab and say, stop, you're done. Or if they aren't above 90%, we agree upon the number at which we're going to stop. One of my last intubations, we started at 54%. The guy touched his face falling off the construction site. We weren't going to mask him. Hit a mouthful of blood. We had one attempt and we were going surgical. It didn't matter where we weren't going to get it up any higher before we started because we couldn't mask the patient with a jaw in 6 pieces. Now we finally look at pulse ox last. Why? Because it's a lagging indicator. I don't think in this group, in this audience, we spend a lot of time talking about why pulse ox is a lagging indicator. But up to this point, pulse ox doesn't matter because you're setting up everything you should already know by looking at the big picture. And this process, what we've talked about it for a couple of minutes, takes us about 10 seconds to go through when we practice it. So staff acceptance. Yeah, this didn't happen overnight. It takes time. So the first way we tried it is the guy I wrote it with, we laminated them and handed them off to a bunch of people and say, hey, try this. Let us know what you think. We got their feedback. We made some tweaks. We made it easy. We put it in every place possible. And we said, well, we really like it. People started trying it. So then we started incorporating it into simulations in our sim lab and making them try it. And all of a sudden, people started using it in the field. They said, wow, this really helped. I wasn't a believer in it, but it made things a lot easier. And their biggest feedback has been, it gives everyone the chance on scene to calm down. It gets quiet for 10 seconds, everyone relaxes, your catecholamines wear off, and then they go when they start. So we practice it all the time. We build this into our simulations, and we perform an RSI and use our checklist in every single simulation. And this is a very hard to read copy of our protocol that's in the middle. But if you'll notice right near the top, right after we identify we need to manage this patient and we are going to suction, the first thing is to clean the timeout before you give any drugs. And we put it into protocol. So if they pull up the protocol to look at it, they have that reminder right there in front of them. And here's where we were in 2014. I'm allowed to share my data. It's quality data. We share it with everyone. We don't do a lot of intubations. We do maybe 2 to 4 a month between our systems. Sometimes we do 8. We have a really busy month. So we have a lot of months where we do too many. And like I said, that's how we define an intubation. And an attempt is if the blade goes in the mouth, that's an attempt. So we took a very narrow definition. Why? Because if we don't look at it hard, we won't identify the problem. We didn't want to gloss it over. We didn't want to hide it. So we made ourselves look really bad. Not because we wanted to look bad, but because we had to really, in reality, where are we? And here's where we are after introducing and making mandatory our RSI checklist. We were 100% first attempt success 6 months in a row, and that has continued on. And we went from a 62% first attempt success to 89%, and we are overall 98% airway managed within intubation within 3 attempts. And that has continued this year. So what have we seen? Well, our staff now use it to get right. They pull out the checklist, they lay it down, and they get all the equipment going down the list, and then they take their time out. So it has helped them speed up their preparatory process when they're on the scene in the back of an ambulance. So they get everything out, they use it, and they have it right there in front of them. It makes them use it a lot more, and our EMS partners absolutely love it. And almost every time we intubate the field, they're calling asking for a copy of our checklist, so we send it to them. We give them the Word documents, and they can make changes to it and make it their own, because only one county around us has RSI. So it doesn't make sense for them to have drugs in it if they're not going to give RSI. So we let them tweak it to what works for them. We teach a difficult airway course for free in our region. It takes about 5 hours. We go out to the counties. We do 5 hours of hands-on skills practice and different intubation. And we just bring copies of it now with us, because every single time they're wanting it. Wow, why hasn't anyone ever thought of this before? It's worked really well for us. We know that intubation is a low-frequency, very high-risk procedure that we do. The data says we should be doing it on less than 1% of our transports. Knowing that we're in critical care medicine, that's probably higher for us than the whole. But if we're intubating on 50-60%, we should really be looking at that closely from a QA side. So it should be a fairly low-frequency skill that we perform. We know that if we set ourselves up for success, we're more likely to be successful in the long run. And we know that it can make a really significant difference.
All right. Well, I hope you've enjoyed this episode. We've been really excited to present these talks to you from the Critical Care Transport Medicine Conference 2016. And if that has whet your appetite for more, I encourage you to join us in person at the CCTMC Conference 2017, which will be April 10th through the 12th at the Wyndam San Antonio Riverwalk Hotel. And for those who have not been to San Antonio, it's a great city. We have a great conference with a wonderful lineup of people. And we hope to be able to talk to you and to meet you and to be able to share ideas. So hope to see you next year in San Antonio, April 10th through 12th, 2017. And you can go on AMPA.org. That's AMPA.org for more information as we get the rollout of this program in progress.
Thank you so much, Chris. And EMSNation, we want to remind you that after watching this lecture podcast, your job does not end. Our lecturers and conference speakers and educators would love to engage with you and really dig into these complex transport questions and optimize the critical care transport of our patients all across the country. So please find us on Twitter at AMPA Docs, AMPA Docs, DOCS, as well as EMS_Nation, and tweet a question to the author of the lecture podcast and tag us as AMPA Docs and at EMS_Nation. We would love to continue the conversation so we can optimize our patient outcomes. This is Faizan Arshad and Chris Fullagar wishing everyone a safe tour.